Welcome to the Chronic Conditions module covering 3 of the most common conditions you will encounter in residential care: diabetes, stroke, and Parkinson's disease. Almost every care home will have residents with each of these. Knowing the basics helps you provide better daily support and recognize when something is going wrong. Diabetes affects around 1 in 7 UK care home residents. Stroke is one of the leading reasons people enter care, and many residents have residual stroke effects. Parkinson's disease affects around 1 in 100 people over 65 and even more in care home populations. The conditions have specific care implications: diabetes for diet and medication, stroke for rehabilitation and risk of further events, Parkinson's for medication timing and falls. This session is awareness level. The deeper clinical management is for nurses and specialist staff. The session is aligned with NICE guidelines on each condition: ING 28 for diabetes, CG 68 for stroke, NG 71 for Parkinson's. We will cover the essentials for everyday care. 5 learning outcomes. Each of the 3 conditions in turn: basics, daily care, emergencies. When to escalate, common pitfalls. Diabetes basics. 2 main types and the implications for care. Type 1. Autoimmune destruction of insulin-producing cells in the pancreas. Usually diagnosed in childhood or young adulthood but can occur at any age. The person produces no insulin and is dependent on insulin therapy, either multiple daily injections or an insulin pump. Both hypoglycemia, low blood sugar, and DKA, diabetic ketoacidosis, severe high blood sugar with ketones, are real risks. Lifelong insulin. Type 2. Insulin resistance, often associated with overweight, though not always. Most common form, around 90% of UK diabetes, is type 2. Treated with diet, oral medications, and sometimes insulin. Many older residents have type 2, some have had it for decades. Some early-stage type 2 can be reversed with weight loss and lifestyle change, but that is rarely relevant in older care home populations. Common complications you will encounter: foot problems, neuropathy, loss of sensation, ulcers, poor healing. Foot care is critical. Small wounds can become limb-threatening. Kidney disease, increased risk of chronic kidney disease and kidney failure. Eye changes, diabetic retinopathy can cause blindness. Annual eye screening is recommended. Cardiovascular disease, heart attack, stroke, peripheral vascular disease. Increased infection risk, UTIs, chest infections, skin infections, all more common. Most residents with diabetes are in stable long-term management. The work is daily monitoring and prevention of complications. Daily care for diabetic residents. Diet. Consistent carbohydrate at meals. The absolute amount matters less than consistency, particularly for those on insulin. 3 regular meals and snacks if needed. Sugar in moderation. The modern view is not no sugar, but consistent and managed. A slice of cake at a birthday party is not a clinical disaster for most residents. Hydration matters. Dehydration affects glucose. For older residents, the diet is often liberalized compared to younger diabetics. The harm of strict restriction often outweighs the harm of slightly higher glucose at age 90. Monitoring. Blood glucose if prescribed, at the time specified. Not every diabetic needs daily glucose monitoring. HbA1c. The long-term glucose marker, every 3 to 6 months in clinical reviews. Weight and blood pressure regular. Foot checks at every personal care, which we will come to. Annual eye screening through the Diabetic Eye Screening Program. Foot care is critical. Look at feet daily during personal care. Any new wound, blister, callus, ulcer needs reporting. Small wounds can become limb-threatening fast. Nail care by podiatrist. Never have care staff cut diabetic toenails because injury risk is too high. Well-fitting shoes. Poorly fitting shoes cause pressure ulcers on diabetic feet, which can become infected and lead to amputation. A diabetic foot ulcer is a clinical emergency, urgent referral to GP, sometimes specialist diabetic foot clinic. The smallest issue with diabetic feet escalates quickly. Take it seriously every shift. Diabetic emergencies. Recap from the first aid module. Hypoglycemia, low blood sugar, sweating, trembling, confusion, irritability, pale, hungry, weak. Severe hypos cause drowsiness, unconsciousness, seizures. Blood glucose below 4.0 mmol, medical emergency if not corrected. DKA, hyperglycemia. Thirst, frequent urination, weight loss, drowsiness, fruity acetone breath, deep rapid small breathing, vomiting, abdominal pain. Develops over hours to days. 999 if severe. Treating a hypo. If the resident is conscious and can swallow safely, give 15-20 grams of fast-acting glucose 3-glucose tabs, a tube of glucose gel, 150 milliliters fruit juice or sugary drink, not diet versions. Retest the blood glucose after 15 minutes. Repeat up to 3 cycles. Once over 4.0, give long-acting carbohydrate to prevent recurrence of sandwich, biscuit, piece of fruit. Document times and treatments and inform the diabetes team or GP, particularly if the hypo was severe or there is a recent pattern. If the resident is unconscious or cannot swallow safely, do not put glucose in their mouth. Aspiration risk. Call 999. Glucagon kits are sometimes prescribed for emergency intramuscular use. If you are trained and one is available, use it as trained. Watch for Hypo-Unawareness. Some residents on insulin lose the warning signs of hypoglycemia and only know when severely low. They need extra monitoring. Stroke. The acute presentation recap from first aid. Fast. Face drooping on one side. Arms, can they raise both equally? Speech slurred, jumbled, or absent. Time 999 immediately if any sign present, and note the time symptoms started or were last seen normal. Other signs. Sudden severe headache particularly suggests hemorrhagic stroke. Visual changes, sudden visual loss, double vision. Sudden confusion, sudden numbness on one side. Loss of balance, unsteadiness. The banner. Treatments for stroke work best within 4.5 hours of symptom onset. Thrombolysis, clot busting medication. Mechanical thrombectomy, physical clot removal, can work up to 24 hours in some cases. Faster transfer to a stroke unit means better outcomes. Note the time of symptom onset, or if not witnessed, the time the resident was last seen normal. Do not give food, drink, or aspirin without clinical clearance. Swallowing is often impaired post-stroke and aspiration is a real risk. The type of stroke matters for whether aspirin is appropriate. Stroke rehabilitation and ongoing care for residents with stroke history. Effects you will see in many residents. Weakness on one side, hemiplegia or hemiparesis. Speech difficulty, aphasia, language production or comprehension, or dysarthria, slurred speech from motor weakness. Swallowing difficulty, dysphagia, often requiring texture-modified diet. Visual field loss, hemianopia, the loss of one side of vision. Cognitive change and mood change, depression is very common after stroke. Care needs. Mobility plan, the right walking aid, hoist for transfers if needed, transfer board for sitting moves. SLT recommended diet level using IDDSI. We covered IDDSI in the food module. Communication aids per SLT, picture cards, written communication boards, AAC devices for severe aphasia. Skincare, the immobile side is at high risk of pressure injury and the resident may not feel pressure normally. Mood and depression, watch post-stroke depression affects up to a third of stroke survivors and is treatable. Preventing further stroke. Anticoagulants or antiplatelets are usually prescribed. Warfarin, DOACs, aspirin or clopidogrel. Never miss doses. Missing antiplatelets can precipitate further stroke. Blood pressure managed through medication adherence. Diabetes control if applicable. Smoking cessation if relevant. Statin therapy continued. Most stroke residents are in stable long-term management. The work is daily support and prevention. Parkinson's disease. The most common type of Parkinsonism, caused by loss of dopamine-producing neurons in part of the brain. Motor symptoms. Tremor, often resting tremor. The limb shakes when at rest, less when in use. Rigidity, stiffness, sometimes cogwheel, on examination. Bradykinesia, slowness of movement. The resident may take longer to start movements, walk slowly, do tasks slowly. Postural instability, particularly later in disease, leads to falls. Mask-like face, reduced facial expression. Soft speech. Non-motor symptoms often more disabling than the motor symptoms. Constipation, very common, often present years before motor symptoms. Sleep problems including REM sleep behavior disorder, vivid violent dreams. Depression and anxiety more common in PD than in age-matched populations. Cognitive change, some PD patients develop dementia, Parkinson's disease dementia or Lewy body dementia. Urinary urgency. The banner. Parkinson's affects much more than movement. The care plan must address the non-motor symptoms which often impact quality of life as much as or more than the motor ones. PD progresses over years to decades. The trajectory is variable. Some residents are largely stable, others deteriorate fast. Specialist Parkinson's nurse input is valuable where available. Parkinson's medication. The most time-critical of all medications you handle. Levodopa is the mainstay. Brand names co-careldopa, Sinemet, or co-beneldopa, Modipar. It replaces the missing dopamine and dramatically improves motor symptoms. Multiple doses through the day, typically every 3 to 4 hours, because the effect wears off. The wearing off and recovery as the next dose kicks in produces the on-off phenomenon. Strict timing must be maintained to keep the resident in the on state as much as possible. Other PD drugs. Dopamine agonists like pramipexole or rotigotine, patch. MAO-B inhibitors like selegiline or rasagiline. COMT inhibitors like entacapone, which extend levodopa's effect. Apomorphine, a rapid rescue injection used in severe off periods. Many residents are on combination therapy. The banner. Missed or late doses cause severe deterioration within hours. The resident who has missed their levodopa dose by an hour can become rigid, unable to move, unable to swallow, in distress, sometimes for hours. Parkinson's UK runs the Get It On Time campaign because PD medication is consistently among the most missed and most consequential medications in care settings, particularly when residents are admitted to hospital and the hospital uses standard medication times rather than the resident's specific timing. If you are administering PD medication, the timing is in the MAR chart for a reason. Treat it as urgent. Plan ahead so you do not run late. If you are running late, ask a colleague to help so the dose is given on time. Parkinson's daily support. Mobility and falls. Freezing, sudden inability to move, often at doorways or when changing direction. The resident is stuck and cannot start the next step. Festination, shuffling steps that gradually speed up beyond control. Postural instability, particularly in later disease. Visual cues help with freezing lines on the floor, counting 1, 2, 3, go. Equipment supports mobility, walking frame, sticks, perch stools. Eating and swallowing. Slow eating, allow time. Dysphagia is very common in PD. SLT review for swallowing assessment if any concern. Tremor affects cutlery use. Adapted plates, weighted cutlery, easy grip handles. Constipation is often a major issue. We covered the importance of fluids, fiber, and laxatives in the continence module. Communication. Soft, monotone speech. Hypophonia. The resident may speak quietly and without much variation in tone. Mask-like face, reduced facial expression, but the emotion is present. Critical point: don't mistake reduced expression for depression or lack of engagement. The resident may be deeply present and engaged but unable to show it visually. Allow time for response. Thinking and speaking are slowed in PD. SLT can offer voice exercises and aids. The LSVT, Lee Silverman voice treatment, is one well-validated approach for some PD residents. Parkinson's care is patient care. The resident has not become less, they are still the person they were, sometimes more present internally than they appear externally. Red flags across all three conditions. Diabetes. Severe hypoglycemia with unconsciousness or seizure. DKA signs: thirst, fruity breath, deep breathing, vomiting. Foot ulcer or infection, urgent referral. Sustained high glucose, need GP review. Recurrent infections suggesting glucose control deteriorating. Stroke. Any new fast signs: 999 immediately. Choking or severe dysphagia, particularly if new. Severe new headache. Sudden cognitive change could be new stroke or another acute neurological event. Antiplatelet or anticoagulant missed, often need replacing rather than skipping. Parkinson's. Severely off, rigid, unable to move, distressed, often medication related and may need urgent dose. Missed or significantly delayed medication causes deterioration, as we covered. New falls or freezing in a worsening pattern. Hallucinations or rapid cognitive change. Choking on food or fluids, dysphagia worsening. Each of these is a senior nurse call at minimum, sometimes 999. Common pitfalls. Diabetes. Birthday cake treated as a crisis when one slice is fine for most older diabetics. Glucose monitoring frequency wrong, either too often, intrusive, or too rare, missing problems. Staff cutting diabetic toenails never. Hypo treated with fast-acting glucose but no long-acting carb to follow, leading to recurrence. Sliding scale insulin without proper monitoring, this is for clinical staff only. Stroke and PD. Aspirin given without clinical clearance after suspected stroke, which is dangerous because the type of stroke matters. Wrong IDDSI level given to a dysphagic resident, causing aspiration. PD medication delayed because the round is busy, which causes the resident hours of suffering. PD medication given with food when the prescription says away from protein because protein interferes with levodopa absorption. Stroke-related depression unrecognized and untreated. Strengthening practice. PD medication on time, every time, this is non-negotiable. Diabetic foot inspection at every personal care opportunity, it takes 30 seconds and catches problems early. Stroke residents check the SLT recommended diet level before every meal. The level may have changed. Hypoglycaemia treated and followed up with long-acting carbohydrate. Do not stop after the glucose has come up. Mood watch for stroke and PD residents. Depression is common, often missed, and treatable. The discipline of getting these right is what separates good chronic disease care from poor. 6 things to take with you. Diabetic foot care, every personal care encounter. Hypo treatment with both fast and long-acting carbs. Fast for stroke time is brain. Stroke diet level checked every meal. PD medication on time, every dose. Watch non-motor symptoms in PD and depression in stroke. Welcome to Chronic Conditions Awareness. Open questions. Resources from each charity provide practical guidance for staff. Sign the induction record after questions.